External
external temporary stabilization system called as split. What is spica? In spica, you are immobilizing both the trunk and the limb. That is
spica.
What is slab?
Immobilization కోసం
Immobilization
సిమెంటెడ్ పిఓపి ది సార్
of circumference of the
హాఫ్ సర్కంఫరెన్స్
full circumference.
Complications of fixation?
What is PTP?
సార్
CFE complications?
ఏవియన్ చేంజెస్ వీ కెన్ అజ్యూమ్ సార్
What else?
ఇంకొకటి లైక్ ఇఫ్ ఈ బేర్స్ వెయిట్ అండ్ ఆల్ దట్ దెర్ ఇస్ అ ఛాన్స్ ఒకటే స్క్రూ వేసినాం
The relationship of tip of the screw to the joint.
టిప్ ఆఫ్ ద స్క్రూ టు ద జాయింట్ నో ఐడియాస్
What happens if screw tip protrudes into the joint slightly, or even cable protrudes into the joint? Immediately patient may develop severe pain
ఓకే సార్
with the restriction of movements in all directions. What is that complication? Chondrolysis, you should be aware of it.
ఓకే సార్
That is the immediate, most immediate
కాండ్రోలైసిస్
after cannulated screw fixation. So how do you ensure it is screw tip is not protruding into the articular surface,
సియామ్
crossing the article? So you have to see in multiple views, not
Views,
just
yes.
one. You have to see that in any projection, tip of the screw is
షుడెంట్ క్రాస్
crossing the article. The head.
And that is not done with the growth plate.
సార్ స్కిఫీ సార్ స్కిఫీ సార్ నో సార్ ఇది డిస్కషన్కి అయిపోయింది సార్ సర్జరీ అయిపోయింది మన దగ్గరనే సార్ ఏం లేదు పర్క్యూటేనియస్ స్పిన్నింగ్ చేసినాం సార్ జస్ట్ 1 వీక్ అయింది ఐ వెంట్ టు ద కేస్
ఎందుకు చేస్తారు ఇన్సెప్టిక్ fixation?
మనకు గ్రోత్ రిస్ట్రిక్షన్ రాకుండా సార్
అదే ఎందుకు వస్తారు?
ఇప్పుడు
ఏమైనా ఎందుకు వస్తుంది?
Huh?
Repair చేస్తే ఎందుకు వస్తుంది?
Chronic. This patient is walking. Before surgery, was he walking with pain? Good. We have that photograph. What is this? Even the excitation was there. So what have you done? How old is the SIP? How old is the SIP? 16 years now. What age it started? No, right, 2000. This problem is deformity or pain? Pain. Only pain. Here, normally it should be there only. Adduction, acceleration is there. That's not survival. But also flexible. The problem is this. So you have to do what have you done? How was this done? You were there for surgery. Tell me what did you do? Is there a slip? there surgery? Homeopathy? Lateral, atrial lateral. Where is atrial lateral now? It is in center now. You choose from lateral side. Not anterior, you have gone. Unless you go to anterior, not get it. Not clear. Now this is not the point, and that is a little more anterior and come to here. That is not done. No, you don't go from lateral side to lateral wall at all. You open this capsule here, go from anterior side, go from the tube, atrium lateral, you have to keep to the center. That would be there. But they already crossed this. There's a big gap, right? No, there's a lucency around this. Why you want this is the screw you have put, right? Lucency is there, why? It has become widened now. It has become wide now. It has become loose. Did you do tenotomy for this? You know, adduction is there, you have to do tenotomy. Here, try to fix it. You think it will, everything, not the normal joint? No. So you have already crossed this. What was the area? This is what is what we think. Crossed already. Okay. Here, what are you seeing in this? This is okay, accepted. Not center, still lower down only. But here, what is that you want to show in this? Where is center? Where is the head? Where is the head? Where is the neck? Place it. No, head. Where is the pin now? Where is the screw? It is down here. That's what I am saying. Not it has been slow. That will be gone again. What is that? What is it? You know your thought. You know this. What is it? That's what I am saying. Is it a stable or unstable? One. Then you want to do any manipulation cannot be done now. Patient is walking with that. Keep on. It's painful. They have to do tenotomy, product tenotomy. Then plan for this. The best thing is at this stage do some outside the joint. After times only. There is no purpose. Product can be done outside. So different surgeries are there which can be done inside, at the neck, and outside. You have to choose accordingly what to do. Not insert the spinning anywhere. Prevent further slip. Or the pain is there, but just fix it further not collapse. That's what it is. It's already crossed. See this? It's already crossed the joint here. You see this? And lucency, I don't know why twice you have drilled it. Drilling is done twice. That's what happened. Was it center or not? You have done tenotomy, and the tenotomy is adductor Jubilee. Why the lucency is there? Both are built,
follow up, right?
first case, sir.
Lucency around the screw threads.
Twice you have done it.
X-ray is good in that.
Emergency,
X-ray
last
mahima.
this is last. Lucency is what I was.
అది ఎక్స్రే మహిమ కూడా ఉంటుంది సార్
ఓన్లీ ఇక్కడేమో సెంటర్ now ఏం చేస్తారు what was it sufficient to fix this? Or further anything you want to do? What do you have to explain? So what I will say is that this will hold for some time. Later I have to come for surgery and do it possibly outside or in the leg. That's what. Then the patient is happy. Okay.
Another important one is strictly it is not the next of finding the head is going here, but the PTA going up. So as if with the western practice, but not more practice is 48
These talks are already.
అది artifact.
And you have to have the washer also inside the otherwise the high chance of proximal migration, improper stability, because even washer gives better stability. It prevents proximal migration. It also the walls. When do you want to remove the screw? 1 year. Why 1 year? Why not 2 years? So when the price is 2 years, 18 years, 1 year, 18 years. You said 1 year, maybe surprise. Because it's not surprise.
It's in 19 years, right?
వదిలే
Okay, right.
వదిలే
This way. Right.
రిఫ్లెక్ట్ ఆపోజిట్ సైడ్ ఆపోజిట్
The
సైడ్
opposite side?
రిఫ్లెక్ట్
Opposite side. Yes, see? No. You're supposed to see or not? Correct, yes. Virtual like, correct? See? Yeah, 2 part, 3 part. Right. What the age?
39 39 ఉందా why not conservative?
No, conservative. Treatment is asking. Why not conservative? How you have to fix it below? Yes. How?
can do
What if you put only KYS across and then leave it? That's the not treatment.
Then use plating fixation, biological fixation. Yes or no?
Yes.
Yes. What is full form of fluids? Proximal nuclear oscillation. And cancella.
ఎక్కడ ఉంది ఫ్రాక్చర్
Good. Fracture means surgery. Fracture ఎక్కడ అని చూడండి ఇవాళ కాంట్రిబ్యూట్ మీన్స్ సార్ రైటా లెఫ్ట్
then you should put this picture first, this round first, and then with traction internal rotation fill it, which gives the true nature of the fracture, whether it is a stable one or an unstable one. Lesser trochanter is intact, then do you call it as intertrochanter? If the lesser trochanter is intact, do you call it as intertrochanteric?
Pertrochanteric or intertrochanteric?
Or cervicotrochanteric? It is almost extending into the upper margin of the lesser trochanter. Most of it is intact.
Okay, correct.
Next.
So what was done? What was done? No, please. ఎందుకు ఇంకేం డిస్కషన్ ఐడియల్ Success is good. No, this done. That is sounding very good.
relatively young man, 40-year man, good bone stock.
You have done this better than this.
So early mobilization is better with CFM or with DF? Huh? Why?
With very confident about that. Right. That's what I know. Example, right?
What is the difference between aseptic loosening versus debonding? Aseptic loosening is between the bone cement and the bone. That is aseptic loosening. Debonding is between bone cement with the metal. That is debonding. So debonding is different. Aseptic loosening.
Very good point.
Yes, sir. You special class
Good morning, sir. This is a 78-year-old male with intertrochanteric. This is a 78-year-old male with intertrochanteric fracture of right femur, sir. Boyd and Griffith type 4, sir. Extension into subtrochanteric area. We have done close reduction interland fixation with long PFN, sir. Extension into subtrochanteric area. Extension into subtrochanteric area, sir.
It is basically subtrochanteric fracture. It is a basically subtrochanteric fracture extended to intertrochanteric.
No.
It's basically subtrochanteric with intertrochanteric
Extension.
and combination.
No.
Stable fracture, unstable fracture.
Unstable fracture, sir.
What is Kyle's fracture?
Tell us.
Kyle's fracture is not only subtrochanteric, intertrochanteric, intercapsular fracturing, and that is Kyle's fracture. KYLES. That is a different generation. That you have to remember. Sometimes Kyle's fracture management is a 10 marks question. Kyle's fracture.
This is a 75-year-old male with intertrochanteric fracture of right femur, sir. We have done close reduction internal fixation with proximal femoral nail, sir. Short PF.
78 is female with intertrochanteric fracture of right femur, sir. Boyd and Griffith type 1, type 2, sir. We have done close reduction internal fixation with short PFN, sir.
This is a 52-year-old female with closed distal and both bone fracture of left wrist joint, sir. This Frickman type 2, sir. Extra-articular. అంటే అల్నార్ స్టైలాయిడ్ కూడా ఉంది కదా సార్. No intra-articular extensions. We have done open reduction internal fixation with plating for left radius. Fracture. We did not see any intra-articular extension in Smith fracture. Smith.
See, even in this, here you see there is some discontinuity. Okay? It is to be treated like a volar button because the major chunk of the distal fragment is the volar displacement. And along with that, the radiocarpal articulation has subluxated. That is the main factor in volar button. Apart from the displacement of the volar fragment, you draw a line, long axis along the distal radius. You should go through the center of the lunate, slipped forwards, subluxated. That is the main reason why you should operate. Okay? This is absolutely not acceptable.
Yes, sir.
Okay?
There is
And
fractures.
this is the reason. It is not a true volar button. It is not a, there is a old ulna
Proximal third
fracture.
ulna, sir. Distal third ulna, sir. Shaft.
So most of the time the distal radial fractures will be usually associated with the ulnar styloid because it's a rotational injuries. Not only a vertical compression or impaction, it also has a rotational component.
Yes.
So the definition of the typical Colles fracture always is incorporated with usually at the end of the definition usually associated with ulnar styloid process. If you read the definition. Here it is not a classical volar button, but behavior is like a volar button. It is broken here. That is why in the post-op X-ray you see, when you have drilled, this fragment is displaced dorsally. The drill bit has pushed the fragment dorsally. Okay. Now you see the alignment has been restored. Lunate is almost going through the center of the lunate. Okay, of course. Okay.
అంటే అంటే ఓలార్ అప్రోచ్ తీసుకుని ఓలార్ ప్లేటింగ్ చేసినాం కదా సార్. డార్సల్ సైడ్ చూడనీకి లేదు సార్ మాకు అట్లా.
నాకు అర్థం కాల, నువ్వు చెప్పింది మాకేం అర్థం కాదు.
కాదు సార్, మనం ఓలార్ ప్లేటింగ్ చేసినాం కదా సార్. ఓలార్ బటన్ సార్. ఓలార్ బటన్.
Do you need to address this fragment or not? Fairly big. It is involving about 1/3 of the dorsal articular margin. The drill bit has pushed it. Drill bit. Probably you may have to put some K-wire. But C-arm lo చూసుకుంటే better. All intra-articular fractures always have a C-arm picture.
Below elbow cast. Mid-prone position. Yes, sir. న్యూట్రల్
Pump. Dorsal.
ఫస్ట్ డే వన్ వచ్చారు పేషెంట్ విత్ ఓలార్ బాటమ్
Polar slab. Sir.
ఓలార్
Polar slab.
ఓలార్ స్లాబ్ డార్సల్ బాటమ్
Dorsal
Dorsal.
slab.
ఓరిస్ ఫ్రాక్చర్
Dorsal slab.
Wrist.
అది కూడా ఇంపార్టెంట్
Neutral,
No.
volar,
Volar or for.
dorsiflexion or
On the palmar
flexion, ulnar deviation, radial deviation.
నార్మల్గా అయితే పాల్మార్ ఫ్లెక్షన్ అల్నా డివియేషన్ చేస్తాం సార్ కానీ
అది కాలేజ్కి దీనికి
కోలిస్
దీని పోలీస్ మరి ఓలార్ బాటమ్
మెకానిక్స్ ఎలా దీంట్లో వాట్ లిగమెంట్స్ ఆర్ దేర్
ఫ్లెక్షన్స్
వాట్ లిగమెంట్స్ ఆర్ దేర్ టు కీప్ ద ఫ్రాగ్మెంట్ ఇన్ స్టెబిలిటీ ఇన్ వాట్ పొజిషన్
రేడియో కార్పల్ లిగమెంట్స్ రేడియస్ కార్పస్ వాట్ ఈస్ కార్పస్
కార్పల్స్
వాట్ ఈస్ రేడియస్
లాంగ్ బోన్ ఆఫ్ ఫోర్ ఆర్మ్స్
లాంగ్ బోన్
These are basic things to learn even. What position to keep immobilized, all to know. All patient may not need surgery. If it's not undisplaced, keep it in position so it will not move. That is important here. Now we are doing surgery, put a plate is not enough. Mechanics should know about this. What displacement is there, what is the position to immobilize.
సో ఇటోపాథోజెనెసిస్ బయోమెకానిక్స్ బోత్ ఆర్ ఇంపార్టెంట్
ప్లేట్ పొజిషన్ ఇస్ గుడ్ సార్ సార్
Here, people have lost flexion of the thumb.
ఎఫ్పిఎల్
After 1 year, patient has lost flexion of the thumb. We should not have been projecting that much beyond. The tendons directly have excursion over the sharp, not sharp, the margin of the blade. I mean, over a period of some months, is likely to cause flexor tendon.
అట్రీష్
Flexor prolapse is very difficult to repair.
ఇట్స్ ఆల్ ఇంపార్టెంట్ సార్
This is a 39-year old female with closed olecranon fracture with radial head fracture of the right elbow, sir.
With what? Olecranon fracture with?
Radial head fracture.
Radial.
ఇక్కడ ఉంది.
Can you show?
what do you call that type of fracture what is Hume's fracture HUMES Hume's fracture common in children or adults
తెలుసు
I don't know what
No. But is there any classification for this?
For olecranon we have got Mayo classification, sir.
No, no,
This
along
is-
with the head radius or proximal radius or this, any, can you classify in something? In children at least.
Sir, Mayo classification for olecranon. We
I
have
am asking
Hotchkiss
you,
classification.
in children, is there any classification for this? Proximal, ulna and radius. Is there a thing when it's called? But Montague is not, variants are not there, so many. This is children fracture, I can say Montague, but is this adult, no?
Yes.
Still you can classify it as Montague, variants of Montague only. This fracture is here, the fracture is here.
What is the variance what is the equivalence what is the difference between what is the equivalence and what is the variance sir favorite question yes sir what is the difference between what is the equivalence and variance sir famous question చెప్పండి sir highlight please highlight the
తెలుసు
చెప్పండి sir ఓ శ్రీకాంత్ నువ్వు చెప్పా బెండకాయలు ఉండే వంకాయలు ఉండే రెండు ఉండేనా అర్థమైందా oranges are there, apples are there, both are same. So which is equivalent, which is variant? Fruits are fruits, ties are ties.
So we have done.
ఈయన గుర్తుపెట్టుకోవాలి తెలుసు ఇప్పుడు అర్థం ఈక్వలెంట్ లెవెల్స్ అర్థమైనా
We have done open reduction internal fixation.
apples and orange both are fruits. Oranges, వినండి సార్, oranges and apples are both are fruit. Both are not same. అది వేరే ఇది వేరే. రెండు మూడు ఆరు, మూడు రెండు ఆరు. ఆ రెండు ఈక్వల్. ఇందుకని రెండు మ్యాథమెటిక్స్ రెండు మ్యాచ్ అవుతున్నాయి. ఇక్కడ ఫ్రూట్స్ బట్ దే ఆర్ నాట్ మ్యాచింగ్ బోత్ ఆర్ సేమ్. యాపిల్ is different, oranges are different. Both are fruits. అది but both are fruits. అది point.
We have done open reduction internal fixation with tension band wiring for right olecranon, sir. Head of radius, we have done nothing, sir. We have done conservative. It is undisplaced, sir. We have put an above elbow cast. We'll try to mobilize her early. If it is symptomatic, we'll go for excision.
Comment on the implant position.
Big fragment there, sir. Big fragment. Yes, sir.
There appears to be articular congestion. There is some depression of the articular subarticular bone, depressed fragment. That is why you could not get anatomic reduction. Great way to go back. It appears that the anterior K wire is going through the
ఇది రేడియోలాజికల్ ఇమేజెస్ కరెక్ట్ లేకపోతే ఇట్లా ఆబ్లిక్ ఇమేజెస్ అండ్ ఆల్ దోస్ సో యూ హ్యావ్ టు హ్యావ్ ట్రూ ఎపీస్ ట్రూ లెఫ్ట్ ఇఫ్ యు టేక్ ఆబ్లిక్ సంథింగ్ లైక్ ఇట్ ఇస్ గోయింగ్ అవే బట్ ఇట్స్
Yes,
నాట్
sir.
ట్రూ
Why again two? What is not enough?
TBW, sir.
Remember one screw can be here,
Then
one screw like this and two. Again, bit of it can be done. Right? But this looks to be more accurate crossing the joint with that. Very, very near to the cortex here. If it breaks,
sir.
likely.
while you put low,
The depth of the screw hole, drill hole, is very close to the cortex.
around the cortex.
Likely to get avulsed. So safer procedure is to put a particle screw and less time consuming, technically less demanding. So to pass the wire and bring it out from the other end of the hole is technically demanding, especially for the medial malleolus. Not here, because you can put a straight horizontal hole in the ulna, because it is triangular bone. In the medial surface of the distal tibia, it is not easy to pull out the SS wire through the hole.
The principle of TBW in patella and this both are same.
Both are same, sir.
Why?
In patella there is pull of quadriceps, sir. In here there is pull of triceps. Here triceps will pull, sir.
Can you say electron is like a patella in opposite, right?
Yes, sir.
సో ద ట్రాక్షన్ ఫోర్సెస్ ఆర్ కన్వర్టింగ్ ఇంటు
Compressive forces.
Distraction force.
Distraction force.
డిస్ట్రాక్షన్ ఫోర్సెస్
This is a 13-year-old male with mid-lung deformity of a right wrist joint, sir. It is traumatic. He has had a history of injury 1 year back, sir. We have calculated the radial inclination, which seems to be
Diagnosis made with this. It is not say midline deformity.
looks like mid-lung deformity.
But patient has come what with deformity risk.
He has come with deformity as well as pain, sir. Both are there.
So what? Is it a general deformity? Sir, we leave that in the
Where
midline.
is manus valgus? Midlands, we typically see manus valgus.
So when you see first time, you can say it's a general deformity as you see for shoulder fracture, right? That's what we do. But midline, not only when you see the X-ray and difference of all the things, the rest you know. Deformity is there.
It is a spade-like deformity. Opposite of dinner core is spade-like or spoon-shaped deformity.
X-ray, you say what does it show?
There is increased radial inclination, sir.
You will call this bending deformity or something else?
We can call it malunited distal and radius.
Bending deformity, that's it. So what is bending deformity? Is it congenital or developmental or something?
Both are there, sir. Congenital, acquired, both are there, sir.
But what is classical thing is only development only.
Yes.
Common in girls, pubertal age, squirting growth, then it has both bilateral instability. Not like this isolated on the right or left.
Yes.
And common in girls. So now if you see the X-ray, can you make out anything wrong? What happened here?
Here the,
So what trauma is there here?
he has given the, he has told that he has fallen.
Please tell me what it is. So they put receiving lower end of radius completely.
The ulnar part and the volar part of the physis of the radius have been damaged. That is
The deficient here, completely is gone.
deficient. Yes, sir. Medial part.
Is it infective?
So that's what is.
No, sir. No, sir.
No, sir.
No, sir.
X-ray looks like
That's what I said. That's what, they had a fall about
most
one
of
day
the
ago.
parents bring the child with some incidental history of injury. Anything in the child will be attributed to some sort of injury. But how much seriously you should consider the history of injury is related to this particular pathology, it is up to us to decide.
So bending deformity is not a true bending. This sometimes we call it a what? False. Or it's called pseudo. Pseudo bending, they are being the disabilities. But you should know exactly the pathology of bending deformity.
Or if
There
it's
is
a
type
humerus
of-
condition. Humerus.
What humors can be there to get the deformed like this?
GCT.
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 But this is history of fall about 1 year ago. Yeah, that's
So here the growth plate is involved, not involved.
Growth plate is involved, sir. Involved, sir.
completely it's gone. Can see this. That's cellular. There is one. What is strength X-ray now? This time?
Here the radial inclination is increased, sir.
No, no, this X-ray. This is Talab. I didn't ask you to. This thing will say what is you are seeing here? Where is ulnar head? Where is
Ulnar head is subluxated dorsally, sir.
how to calculate for this variance? Clinical variance, radiological variance.
And రేడియోలాజికల్లో కూడా అల్నార్ న్యూట్రల్ ఉంది సార్ క్లినికల్ కూడా న్యూట్రల్ ఉంది
No, that's what I'm asking. Because or not?
న్యూట్రల్ ఉంది సార్ న్యూట్రల్
How to do it for the clinical variance? How to examine?
put a finger on the tip of the radial styloid, put a finger on the tip of the ulnar styloid.
Rather than the tip of the nail. How to figure out the unless you feel one is correct also. Put your index or both index.
Both the index.
The nails at the tip. Then you can measure how much is that.
This is called as styloid index.
Styloid.
Which styloid is at lower level, radial or ulnar?
Here radial is at lower level.
Normally,
Normal.
normally ask. You have a doubt. Simple yourself.
Normal, very low. Radius or
Radius.
Radius and tell.
Radius.
Thyroid radius.
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 simple concept. So evaluation of the styloid index is also important to assess for the Cooley's fracture reduction.
Relation of better radius to the thyroid process. Allah. Where is Allah thyroid?
On the medial aspect.
For the posterior ligament. What you're feeling in the head is on the head of the Allah. When you get the thyroid? Posterior to that, if you put your tip of the nail and you can see there is a projection. That is what Allah's thyroid. Radius thyroid is the thyroid.
So it is called as allotment of the ulnar head. Also called as piano sign positive. What is the cause for piano sign positive?
DRUJ injury.
Huh?
DRUJ injury.
What is the DRG? I don't know.
Distal radial ulnar joint.
Distal radial ulnar joint. What is that? What is TFCC?
TFCC is a fibrocartilage.
Both are same or different?
Different, sir. Different.
How different?
TFCC is at the distal ulna, sir. Whereas DRUJ is somewhere over here, sir.
Show me the pointer. Use the pointer.
We are getting late.
Right.
We are
You know,
getting
you know what it is.
Already 10 o'clock.
DFCC should know what is DRH is. Diana sign 23.
We have done corrective radial open wedge osteotomy with ulnar shortening osteotomy for right wrist joints. Reconstruction. Yes. These are the intra pics, sir. This is before bone grafting of the radius, sir. This is after bone grafting of the radius. This is the ulna after bone graft we have taken from ulna and inserted in the. Yes, sir.
Which part of the ulna? Ulna, which part?
Cortical part. Cortical part.
Upper third, middle third, lower third.
Lower third.
Show the pointer. Just a second. Cursor pointer.
ఇక్కడ. Yes, sir. Yes, sir. Both, sir.
Both, sir.
I have collected. Yes.
Yes, sir.
So all very important, sir. Very important.
7 years female with spastic diplegic cerebral palsy, sir. GMFCS level 1, sir. This is a gate video, sir. Jumping gate, sir. Yes.
Sir,
Walking.
is more than 90 with hips and knees are flexed.
Flexion. Equinus gate.
No clonus, sir.
No, sir.
The hip also is internally rotated.
Roughly
Left
70,
side.
80, 60, 70 degrees. Left side, sir. Yes, sir. Yes.
Good morning, sir.
Good morning.
What is it?
Cerebral palsy.
Continue.
Different.
Adductors are tight, sir. The
Hamstrings.
hamstrings on the left side are tight, sir. Bilateral tendoachilles are tight, sir. Contracture, sir.
Is there a contracture or only spasm?
Spasms.
For only spasm, you should not do AME. If it is spasm, is a correctable deformity. Unless there is a joint contracture. It is going to worsen the problem.
Make it more weak.
Positive, sir. In both the sides there is gastrocnemius contractures. Gastrocnemius.
So how to distinguish whether it's a contracture or a spasm? You have to clinically assess, and the management depends on that.
We should do R1 and R2.
Literally means joint contracture. Spasm and contracture produces a similar clinical picture. So how to assess whether it's a contracture or a spasm?
Fast stretch, slow stretch we can do.
Yeah, fast stretch and
Slow
sudden jerky stretch, and gentle stretching by diverting the attention of the patient. If you are able to bring the joint, ankle joint at least up to neutral, it is not a contracture. So PA lengthening should not be done if it is pure spasm. Other procedures like Strayer's release in the proximal soleus or partial soleal neurectal.
Correctable or not yet?
Correct.
Very important assessment before undertaking the procedure.
And in the OT, once you give anesthesia, that's the best way. Examination and anesthesia.
Before an induction, that's not.
Under anesthesia, deformity correctable means what? Is a contraction or a spasm?
Spasms.
Okay, got it. So what was done?
We have done single event multi-level surgery, sir. We have done bilateral adductor tenotomy with bilateral tendo-Achilles lengthening and left hamstring lengthening we have done, sir.
So what is that showing?
This is the hamstrings,
Finger.
the tibial now,
Tibial
sir.
nerves.
Tibial now.
Why female line explain? Is there need to explain or not? Yes, there is need.
No need to.
You have to think for the branches of this, for the soleus as well as gastrocnemius, and check that. It's possible.
What is fractional lengthening?
We have done fractional lengthening for semi-membranosus and biceps femoris, sir. Not plasty, sir. For semi-tendinosus and gracilis, we have done Z-plasty, sir.
Petri
Petri
cast.
cast.
Make him walk next day.
Next.
Thank you, sir.
Good morning, sir. This is case done in Unit 2. 48-year female with 4 months old undisplaced.
No general practice. Who is doing general practice?
Me, sir.
So only one X-ray you have.
Yes.
Okay, okay.
48-year female with 4 months old undisplaced fracture of proximal and middle third left tibia fracture, sir.
4 months old, how can be undisplaced?
Sir, this is a mistake, sir. At presentation, it was undisplaced fracture. We applied above knee slab. The patient removed the slab and went for native treatment and came to us at 4 months. Sir.
So what is it now?
It's
4 month X-ray?
yes, sir.
People are intact.
Yes, sir. Then open reduction with ILN for left hip.
Go back, go back. Show me the radiological features. What are they? What do you see?
Sir, malunited.
Is it malunited?
Yes.
No, you.
Sir,
What are the radiological features?
Severe OA with valgus.
Okay, osteoarthritis is there. At the fracture site, describe the fracture.
So fracture ends as sclerotic and transverse proximal middle third junction, sir. Angulated. Yes, sir. Complete fracture.
You and is comminuted.
only read the AP view, look at the letter.
Mm.
There is a clear-cut fracture line with margins, fragment margins are sclerosed.
Yes.
And probably the medullary cavity is closed.
Closed, sir. Intraop it was closed. Distal fracture.
Are there any frank mobility at the fracture site
Y-
clinically?
Yes, sir. So we done open reduction, internal fixation with interlocking nail for left tibia, and we did fibulectomy, sir, to gain the alignment.
Bone grafting was done.
Sir, we used this fibulectomy part only because it was. Yes.
Very poor osteogenic
Mm.
potential for the fibula. Purely cortical, doesn't have cancerous component. You can only make it like a
Mm. Supportive, not for osteogenic.
biology is
Mm.
okay.
Mm.
It is lack of adequate immobilization that is the cause for the non-union should be assessed. Atrophic or hypertrophic or oligotrophic.
Yes.
So biology is fine. Mechanically it is disturbed. Okay. It's always safer to do a cancerous.
Bone grafting is always safe.
So my topic for
Weight-bearing limbs, 44 cancerous structures. Weight-bearing limbs. What are the non-weight?
yes.
You have to protect the graft parts. So the nail is not a micromotion. With the plate we don't have it.
The topic is management of intercondylar fractures of humerus by triceps reflecting anconeus pedicle and olecranon osteotomy approach. Taken from Journal of Arthroscopy and Joint Surgery.
Mm. You go back, read that abstract. We've been saying.
Yes, sir.
You,
Yes. Introduction: intercondylar fractures of the distal humerus are uncommon and pose a considerable challenge to even the most experienced orthopedic surgeon. Our study aimed at comparing one described surgical approach to fix them, the trap approach, which involves elevation of a flap comprising of triceps and anconeus from distal to proximal, with more popular olecranon osteotomy approach. Introduction: incidence is 2 to 6% of all adult fractures, mostly extra-articular. Bicolumnar intra-articular is 37%. Bimodal distribution: in young males it is usually with high energy trauma, and in elderly it is trivial trauma because of the osteoporotic bone. Most difficult to treat because of poor assessment, complex anatomy, and proximity of neurovascular bundles. Key factors for successful outcomes are anatomical reconstruction, rigid fixation, and early mobilization. Aim of the study is to compare functional outcomes in patients with intra-articular fractures of distal humerus in terms of tricep strength, post-op range of motion, Mayo elbow performance score, operated with either trap or olecranon osteotomy. So this is distal humerus A classification.
yeah, gone.
Materials and methods are prospective comparative study. 74 patients are taken, 35 in olecranon osteotomy group and 32 in triceps trap group. Yes, sir. On even an odd date of admission, they have randomized, simple randomization they have done, sir. From July 2016 to Jan 2019. Inclusion criteria is age 18 to 59 years, closed intercondylar fracture, grade 1 open and type C fracture. Exclusion criteria: grade 2 and 3, patient unfit for surgery, injury greater than 3 weeks old, age less than 18 and more than 70 years, associated ipsilateral upper limb fractures or neurovascular deficit. So this is demographic profile of the studies. Olecranon osteotomy is well-described approach for complex intra-articular distal humeral fractures. Potential complications include prominence or migration of hardware, displacement or non-union of osteotomy, triceps weakness. This have included the image to show the surgical steps. This trap approach mobilizes triceps and anconeus muscle of the posterior humerus and proximal ulna and also provide adequate exposure of distal humerus. The post-op protocol they followed is elbow was splinted in 110 degrees of flexion and elevated for 2 days to reduce edema. Active assisted range of motion was started on third day and splint was used intermittently for 2 weeks. Follow-up at 2 weeks from the date of surgery and then at 4 weeks, then monthly for first 6 months, and after that every 3 months till last follow-ups. At each follow-up, patients were evaluated for pain, swelling, signs of infection and range of motion. X-ray, API and lateral views are done. At final follow-up visit at 18 months, parameter compared are elbow range of motion, tricep strength and MEPS score. MEPS score comprising of pain, motion, stability and functions. If it is greater than 90, it is given excellent, 75 to 90 is good, 60 to 74 fair and less than 60 poor. So results in between both the groups were comparable in terms of time taken for fracture union, average arc of motion, mean degree of maximum flexion, range of pronation, strength of triceps muscle and range of supination between two groups at 18 months. However, extension deficit was significantly more in group olecranon osteotomy as compared to TRAP groups. Complications associated: a superficial infection in 2 patients in olecranon osteotomy and 3 in TRAP approach. No deep infection. Prominent K-wires in 2 patients in group olecranon osteotomy. Screw loosening in 2 patients in group O and 3 in group TR. There's no non-union or delayed union. Bulla and skin necrosis, 1 patient in group O and 2 in group TR. Ulnar neuropathy equally in both patients. There's no radial neuropathy. Need for implant removal was present in 2 patients in group O, 3 in group TR. No primary implant failures. These are the cases they have included in the journals. X-ray showing type C intraarticular fracture. This is done following TRAP approach. They didn't mention the X-ray, follow-up X-ray time, sir. This is second X-ray they have done. Yes.
They said it included only C1. C1 means there's no.
No. Yes, sir. C3, they mentioned C3 also. Yes.
It said C1. Go back up. Grade 2, 3 are excluded.
So the description and the tables were not matching actually in the paper.
Why did you select? No, why did you choose such an article? What did you ask?
Sridhar, sir.
So read properly. Okay, one.
Usually olecranon osteotomy because of the adequate exposure, but in this, yes, sir. In this they told it is TRAP. The second case, sir. And third case. Done.
This is immediate post-op. That's why they don't give time. This is immediate post-op.
Yes.
All cases.
The clinical outcome of TRAP patient and both cases they mentioned.
Okay.
Conclusion, sir. Driscoll described TRAP approach which offers good exposure of distal humerus fractures without needing an olecranon osteotomy and preserve the neurovascular supply to the anconeus. Chen et al. Found no significant difference in flexion, extension or MPS scores between TRAP and olecranon osteotomy, supporting their functional equivalence. Ozer et al. Observed TRAP approach maintains good tricep strength with minimal complications, confirming its effectiveness. Wilkinson et al. Showed what this is the final line they include in the conclusion. Sir. This study concludes TRAP is a safe and effective alternative.
So there is no difference. You can choose either of them.
Yes, sir. They only mentioned on basis of
So last slide, your critic?
Yes, sir, this one.
No, you are critical.
Sir, they have
Last slide we said
yes.
you have to write a critic about starting from title.
Yes.
Did you prepare?
Yes, sir, I prepared. Didn't mention here in the PPT.
Where is it?
Didn't mention here, sir. PPT.
Prepare it now and show us.
Yes.
Because every time. No. One last slide is, we said all titles, whether matching or not. You prepare it and show to me.
Yes, sir.
Again, one more additional point is, we might have done quite a good number of conferences here. You can also include your
No.
cases here, whatever been done in our institute. And it's a very common practice. And we could have projected our results also.
Yes, sir.
That means you have not put enough work in it. See, such an article, once you read, you can discuss again, sir, this is what controversy is there. There is no point in, because you are wasting your time, everybody's time. Isn't it?
This is put one day before the
Ah.
seminar day. The topic is put.
Yesterday only you put it in the group.
So there is no time for.
That's, I think that's. Who is presenting next Thursday?
At least 3-4
Did you choose the topic? Now you alone go to library, read see these 4 articles, come back in the clinic 1 o'clock. I will finalize. Okay. But this is very bad. We keep telling everything. You are not. And by 1 o'clock your beard should be off.
Yes, sir.
You come to OPD, clean shaven.
Yes, sir.
Okay. I think they're taking very. He's there waiting outside. Okay, any more X-rays?
Done, sir.
Thesis first years. Done. Come to the front. All the first years. Come all of you front. Front means not front row, to the dais. You don't get your thesis, just come and talk to us. All of you come. 10 of you. How many are there? Come. 6, 7. 3 more. Where are they? Other 3, where are they? When they are going to present it? Did they take it permission? Okay. How much is it complete? Yes. And those 2? They'll check. Tell them they take it. Huh? Already completed. It's important. That's, I think, don't learn bad habits from your seniors. Because these 3 years are very important for you. Whether you become a good orthopedic surgeon or not decides. And whatever we say is for your own good. Look. Usually see individual guides and any change modification, we discuss and probably this week have submit. This week, today. Tomorrow. Upload. Yeah, that's what.
ఏమంటావు